Hello everyone. Today we are going to explore joint derangements and dysfunction, focusing on loose bodies, hypermobility, and hypomobility. These conditions represent mechanical disturbances within joint that affect joint congruency, movement quality, load distribution. So, understanding these dysfunction is essential for physiotherapists because they directly influence pain, stability, functional movement. So, in this section, we will explore biomechanics, clinical presentation, assessment, and management strategies. So, what is joint derangement? Joint derangement refers to structural or mechanical disruption within a joint, leading to abnormal movement or restriction. Key concept: normal joint function depends on congruency of articular surfaces, ligamentous integrity, neuromuscular control. When any of these are disrupted, joint dysfunction occurs. Types of joint dysfunction: loose bodies. Dysfunction definition: loose bodies are free fragments of cartilage or bone within the joint space. Causes are trauma, osteoarthritis, osteochondral injury. Pathomechanics: loose bodies can interfere with joint movement, cause mechanical blockage, lead to joint locking. So, what are the clinical presentation? Intermittent locking, catching sensation, pain during movement, reduced range of motion. Hypermobility. Definition: hypermobility refers to excessive joint movement beyond normal physiological limits. Causes: ligament laxity, connective tissue disorders, or repetitive strain. Pathomechanics: excessive mobility leads to joint instability, poor load distribution, increased injury risk. Clinical presentation: joint instability, recurrent subluxations, pain after activity, fatigue. Key insight: hypermobility is not always symptomatic but becomes problematic when stability is compromised. So, hypomobility. Definition: hypomobility refers to restricted joint movement, causes joint stiffness, capsular tightness, post injury fibrosis, degenerative changes. Pathomechanics: restricted movement leads to altered biomechanics, compensatory movement patterns, increased stress on adjacent joints. Clinical presentation: stiffness, limited range of motion, pain at end range. Biomechanical principles: joint functions depends on mobility, stability, motor control. Mobility allows movement, stability maintains control, motor control coordinates movements. So the core concept is a dysfunction occurs when there is an imbalance between mobility and stability. What is the examples? Hypermobility: too much mobility, not enough stability. Hypomobility: too much stiffness, limited movement. Clinical assessment: subjective examination, assess symptom behavior, locking or instability episodes. Functional limitations: observation, look for joint alignment, swelling, movement patterns. Range of motion testing: hypermobility, excessive range, poor control. Hypomobility, restricted range, capsular pattern. Special tests for hypermobility: Baton score, joint laxity tests. For loose bodies, joint locking signs, imagine confirmation. Functional assessment includes gait, task specific movement, stability during activity. Clinical reasoning framework. Step 1: identify type of dysfunction: mechanical block, loose body; instability, hypermobility; restriction, hypomobility. Step 2: identify primary driver: structural, neuromuscular, biomechanical. Step 3: assess impact on function: movement quality, load tolerance. Physiotherapy management: loose bodies management, referral for imaging, possible surgical removal. Physiotherapy role: forced intervention, restore mobility, strengthen joint, improve function. Hypermobility goals: improve stability, enhances motor control. Intervention: strengthening, focus on stabilizing muscles, core control. Proprioception training improves joint awareness, neuromuscular control. Activity modification reduces excessive joint stress. Hypomobility goals: restore movement, reduce stiffness. Interventions: manual therapy, joint mobilization, soft tissue techniques. Stretching improve flexibility. Movement retraining restores normal movement pattern. Clinical case example: Case 1: loose body. Patient present with knee locking, intermittent pain. Clinical reasoning: possible loose body. Management: relief for imaging, post-surgical rehab. Case 2: hypermobility. Patient presents with the recurrent ankle sprains, instability. Management: strengthening, proprioception training. Case 3: hypomobility. Patient presents with the restricted shoulder movement, stiffness. Management: mobilization, stretching, functional training. So, key take home points: joint dysfunction affects movement and stability. Hypermobility and hypomobility represent opposite ends of dysfunction. Management must be individualized. Physiotherapy focuses on restoring optimal movement. So, joint derangements highlight the importance of balance between mobility and stability in musculoskeletal health. As physiotherapists, our role is to identify dysfunction and guide the body back to efficient, controlled movement. Thank you for joining this advanced discussion. I will see you in next video.